COVID-19, caused by the SARS-CoV-2 virus, has been shown to cause a range of musculoskeletal symptoms, including arthralgia, joint pain, and arthritis, which can mimic rheumatoid arthritis (RA). Post-COVID-19 inflammatory syndromes have further complicated this by presenting with persistent joint symptoms that may resemble autoimmune diseases. Here's an overview of how COVID-19 and its sequelae can mimic RA, along with key differentiating factors. 1. COVID-19 and acute arthritis. Clinical presentation. During acute COVID-19 infection, some patients develop arthralgia and, less commonly, true arthritis. Joint symptoms can range from mild joint pain to more severe polyarthritis. The arthritis can involve multiple joints and may be symmetric, affecting the small joints of the hands, wrists, and knees, patterns that resemble RA. COVID-19-related arthritis can occur in both the acute phase of infection and as a post-viral syndrome, sometimes persisting for weeks or months. COVID-19 patients can also experience myalgia, muscle pain, and fatigue, which can mimic symptoms of systemic inflammatory diseases like RA. Laboratory findings. RF and anti-CCP antibodies are usually negative in COVID-19-related arthritis, unlike RA, where these markers are often positive. Elevated markers of inflammation, such as CRP, ESR, and ferritin, are common in COVID-19, especially during severe infections, but these are nonspecific. Testing for SARS-CoV-2 via PCR or antibody testing confirms recent or past COVID-19 infection. Differentiating features. COVID-19-related arthritis is typically self-limiting and resolves over time, whereas RA tends to be chronic and progressive. The presence of other typical COVID-19 symptoms, such as fever, cough, shortness of breath, and loss of taste or smell, can help distinguish COVID-19-associated arthritis from RA. COVID-19 arthritis does not usually lead to joint erosions on imaging, unlike RA. 2. Post-COVID-19 syndrome, long COVID, and chronic arthritis. Clinical presentation. Many individuals who recover from acute COVID-19 infection go on to develop long COVID, a condition characterized by persistent symptoms lasting weeks to months. Musculoskeletal symptoms, including joint pain, stiffness, and swelling, are common features. These joint symptoms can resemble chronic inflammatory arthritis, and in some cases, patients may present with symmetric polyarthritis, similar to RA. Joint symptoms in long COVID may occur in conjunction with fatigue, brain fog, and muscle aches, which are also common in autoimmune diseases like RA. Laboratory findings. Similar to acute COVID-19, RF and anti-CCP antibodies are usually negative in patients with post-COVID arthritis. Inflammatory markers such as CRP and ESR may be mildly elevated, but are often less pronounced than in RA. Some patients with long COVID develop autoantibodies, but they may not be the same as those found in RA, e.g., anti-nuclear antibodies, ANA, or other nonspecific antibodies. Differentiating features. The history of COVID-19 infection and the presence of other long COVID symptoms, e.g., chronic fatigue, dyspnea, cognitive impairment, help differentiate long COVID arthritis from RA. Long COVID symptoms tend to fluctuate and may improve gradually over time, whereas untreated RA typically progresses and causes joint damage. Unlike RA, imaging studies in long COVID arthritis do not show joint erosions or synovial proliferation. 3. Reactive arthritis after COVID-19. Clinical presentation. Reactive arthritis is a post-infectious arthritis that can develop after various infections, including viral infections like COVID-19. COVID-19 has been reported to trigger reactive arthritis in some individuals, presenting with asymmetric oligoarthritis or polyarthritis affecting the lower limbs, knees, ankles, and feet, which can mimic RA. Reactive arthritis may also involve enthesitis, inflammation of tendons and ligaments, and dactylitis, swelling of an entire digit, features more typical of spondyloarthropathies, but can occasionally overlap with RA. Laboratory findings. RF and anti-CCP antibodies are negative in COVID-19-related reactive arthritis. Synovial fluid analysis typically shows a mild inflammatory response with negative cultures. Inflammatory markers, CRP-ESR, may be elevated, but less so than in RA. Differentiating features. Reactive arthritis is usually self-limiting and improves over time or with treatment, the NSAIDs, corticosteroids, whereas RA requires long-term immunosuppressive therapy. A history of recent COVID-19 infection is a key clue in diagnosing reactive arthritis related to SARS-CoV-2. Reactive arthritis often involves lower limb joints more than the small joints of the hands, which are more characteristic of RA. COVID-19 and autoimmune disease triggers. In rare cases, COVID-19 has been linked to the new onset of autoimmune diseases, including RA-like arthritis. Patients may present with persistent symmetric polyarthritis after COVID-19 infection, which can fulfill classification criteria for RA. The exact mechanism by which COVID-19 triggers autoimmune diseases is not fully understood, but molecular mimicry, immune dysregulation, and cytokine storms during infection may play a role. Laboratory findings. Some patients may develop positive RF or anti-CCP antibodies after COVID-19, mimicking RA. Inflammatory markers such as CRP and ESR may remain elevated for extended periods. ANA or other autoantibodies can also be detected, suggesting an autoimmune process triggered by the virus. Differentiating features. COVID-19 induced autoimmunity might resemble RA, but the diagnosis is complicated by the fact that these autoimmune phenomena are often newly triggered by the infection. Time course and history of COVID-19 infection can provide context, but in some cases, it may be challenging to distinguish between post-COVID autoimmune arthritis and new-onset RA. Imaging studies may eventually reveal joint erosions in patients who develop true autoimmune arthritis following COVID-19, but this takes time. 5. Multisystem inflammatory syndrome in adults, MIS-A. Clinical presentation. MIS-A is a rare but severe inflammatory syndrome that can occur after COVID-19 infection, affecting multiple organ systems, including the joints. Patients with MIS-A may present with polyarthritis, along with fever, rash, cardiovascular involvement, and gastrointestinal symptoms. The arthritis seen in MIS-A is acute and may be mistaken for RA in the early stages, particularly if joint symptoms are prominent. Laboratory findings. RF and anti-CCP antibodies are typically negative in MIS-A. Inflammatory markers are significantly elevated, including CRP, ESR, ferritin, and D-dimer. Other laboratory findings may include lymphopenia, thrombocytopenia, and evidence of multi-organ involvement, e.g., elevated liver enzymes, myocardial damage markers. Differentiating features. The multi-system involvement and severity of MIS-A distinguish it from RA. MIS-A requires prompt recognition and treatment with immunomodulatory therapies, e.g., IVG, corticosteroids, but it is generally self-limiting once treated, whereas RA is a chronic, progressive disease. Summary of